speaker to the podium. Our next speaker is Dr. Elizabeth Yen. She's a pediatric gastroenterologist at UC San Francisco Benioff Children's Hospital. She attended the Weill Medical College of Cornell University in New York City and has trained at Seattle Children's Hospital as well as Boston's Children's Hospital. Dr. Yen has clinical expertise in the GI manifestations of cystic fibrosis, which those of us who have been dealing with disease know is a big part of what we deal with in CF. Here to discuss various methods of addressing GI issues in people with CF is Dr. Elizabeth Yen. Please help me welcome Dr. Elizabeth Yen.
Thank you. Well, thank you for the invitation to speak in this forum. I'm new to the Bay Area, having moved here about a year ago. So it's a very nice place to be and definitely happy to be here. So I'll be talking about how to take care of your CF gut. And before I get started into my talk, I just want to give you an overview of how I got here. So apart from my pedigree of what schools I studied at, been cross-country twice, started off in New England, then over to Seattle, back to New York, then New England again, and finally decided that really the West Coast is where I wanted to be. I ended up in cystic fibrosis as an area of expertise because my husband started working at Vertex actually on the ivacaftor project, and at home he was so excited about the drugs prospects, and we talked so often about cystic fibrosis, and he really just inspired me to also look into the GI aspects of cystic fibrosis and to provide a service where actually at Boston Children's it was a little bit lacking at the time. So they welcomed me with open arms into the CF Center there, and it's been a great community to work with on both coasts. So first I want to talk about how the gut is different in patients with cystic fibrosis versus the normal gut. And I'm going to go to what you know. I wonder if do we have a pointer? Yes, we do. Okay. The pancreas. The pancreas, we all know, is a sentinel organ in cystic fibrosis, meaning the most severe forms of cystic fibrosis have complete damage of the pancreas. And even with milder forms of cystic fibrosis, the pancreas is very significantly affected. And this has a lot of consequences to the function of the gut. The function of the gut is to digest and absorb the nutrients that we eat. And the function of the pancreas is to produce the enzymes, or the little workhorses that break down the food that we eat into particles that can then be absorbed by our gut and utilized by our bodies. Specifically, the fat in our meals really relies on many functioning enzymes from the pancreas, as well as, and I'll touch on it later, bile from the liver. But all of the nutrients, fats, proteins, and carbohydrates, first have to be broken down to then be able to be taken up into your body and used for energy. Moving along, away from the pancreas and into the lumen of the intestine, or the inside of the intestine, you have the contents. And the contents are not just the food that you eat, but also the fluid that is produced by your GI tract. First, you get fluid from the stomach. And the stomach, we know, produces acid. And the acid is good to help start off the digestive process. It also helps keep a somewhat sterile environment in the upper part of the GI tract. And that acid then, as it travels into the small intestine, normally gets neutralized. So the pancreas, again, the importance of the pancreas, produces bicarbonate, which meets up with the acid from the stomach and makes it into a more watery type of substance, makes it neutral pH. And that is key to be able for the enzymes that are coming from the pancreas to be able to function. Those enzymes do not work well in an acidic environment. However, when you don't have pancreas functioning well, you don't get the bicarbonate from the pancreas, and therefore you have an acid level in the upper part of the small intestine where you should be having digestion going on. You should be having those pancreatic enzymes working on all of the food that you just ate to start dissolving them and making them into something that you can absorb. So in that acidic environment, you have to wait a little bit longer, further along the small intestine, to be able to get to that neutral environment, because the small intestine itself produces some of that bicarbonate, so you do get some bicarbonate production. It just takes longer for it all to de-acidify, to get neutralized. So therefore, you end up having a delay in the start of action of the pancreatic enzymes, whether they're taken by mouth or if you still have some residual produced by your pancreas. Then moving on to the liver, also part of the gut. The liver produces bile, and bile production in CF is also altered. We don't understand exactly why or how it's altered, but it's not totally normal. So the problem in the liver with CF is not just that the bile ducts get plugged, because that happens too, to varying degrees, and some people have more significant liver disease than others, but even apart from that, the bile is not an adequate type of bile to help in the digestive process. There is bile, it's just not a normal content of bile. And the bile is like a soap. It takes the fat that you eat and it makes it into tiny, tiny, tiny little pieces that then the pancreatic enzymes can work on the surface of. So that is also a very important function in the GI tract that's altered in CF. And then we have the motility, or the movement of the GI tract. The intestine, the small intestine, it seems slows down in CF. And we actually have some hard data on that. Some old data that Dr. Drury up in Toronto developed a while, maybe it was like, I don't know, 30 years ago. And now we have some pills, intestinal pill cameras and pill sensors that you can take, and it measures how long it takes to go from the start of the intestine until the end of the intestine, or the colon. And it's clear that the small intestine transit time is much longer than in a normal intestine. However, the total GI transit time seems to be normal. So once the buildup of whatever residue gets into the colon, it seems to move along just fine, and in some cases faster than normal. Additionally, we do know that the mucus is thicker in CF patients. And again, this goes back to the basic problem in cystic fibrosis, that the mucus, just as it's produced in the lungs, lots of mucus is produced in the intestine, throughout the intestine. But in the absence of sufficient bicarbonate and water, it is thick and doesn't allow the normal amount of movement across its surface. This creates a problem for blockages. In newborns, we know this as meconium ileus, where a newborn can have a blockage already in the womb, and it presents at birth with a completely blocked intestine, sometimes requiring requiring immediate surgery, because there's also an associated perforation. And sometimes this can be cleared out with just gentle removal of the blockage in surgery. Other times, a piece of intestine has to be cut out because it's been very damaged. In older children and in adults, there is the problem of distal intestinal obstruction syndrome, or DIOS. And DIOS affects everyone, not just patients who have had a history of meconium ileus. So therefore, we don't think it's something a genetic predisposition. It seems to not have any genetic linkage so far in the studies that have been done looking at this. So with those abnormalities in the gut, it's reasonable to expect certain symptoms, and the classic symptoms that we always ask for and we're watchful for is the oily stool or large, bulky, floating stool that is indicative of fat malabsorption. Because of fat malabsorption and also because of a higher calorie requirement in general, some additional GI complaints include poor weight gain or weight loss due to malfunctioning gut. Reflux is also a very common symptom, reflux of acid from the stomach up into the chest, into the esophagus, sometimes as high up as your vocal cord area. Abdominal pain, that affects everyone, not just patients with CF, but it has certain implications in patients with CF. And bloating, or that sense that your belly is really full, as well as constipation. So I'll tackle these GI complaints in turn. But I wanted to show you again this schematic about how I think pancreatic insufficiency is so important when we think about the different symptoms that a patient might experience with cystic fibrosis. So at the top is pancreatic insufficiency, and that, as I mentioned before, leads to the low intestinal pH because of the absence of bicarbonate production in the small intestine. In order to compensate for that delay in digestion, we have a slowing of the motility of the small intestine. Now, slowing of the motility can lead to bulkier stool if you have poorly digested foodstuffs that's getting further down into the lower part of the small intestine or the ileum. And then this is what can lead to problems when you have thick inspissated mucus, or that thick mucus lining the lower part of the small intestine, and a lot of bulk. Then you get into the problem with DIOS. With the distal intestinal obstruction, where you can present with abdominal pain, vomiting, loss of appetite, bloating. And we can talk about that more in a little bit. Constipation also is a different problem, different from DIOS, and sometimes difficult to distinguish from DIOS. But an abdominal x-ray is usually helpful in helping differentiate DIOS from constipation. And constipation in CF can be very subtle, because you're used to thinking constipation means you're not pooping. Well, with CF, you eat a lot. You eat more than the average bear, if you will. And so therefore, you should be producing more stool. So it's pretty normal to have 3 to 4 bowel movements a day in patients with CF. On the other hand, you know, where normally we say, okay, 1, 2 bowel movements a day is normal for the general population, and then someone with CF has usually gone along having 3 to 4 bowel movements a day, and then suddenly they're having 1 to 2. Well, that seems better, but actually it's not, because you're building up the stool, and that then eventually leads to abdominal pain, gassiness, bloating, and loss of appetite. And I harp on loss of appetite because then you start losing your appetite, it starts impacting your weight, and it starts impacting your nutrition. And we all know how important nutritional status is for the overall well-being and outcomes in patients with CF. This is a picture of Dr. Dorothy Anderson, who you're probably familiar with. She was the first physician who described cystic fibrosis of the pancreas and really had seminal research in this area, helped develop the pancreatic enzyme replacement products that were critical for nutritional support in getting patients with cystic fibrosis, little babies, to grow older with their disease. We now have pancreatic enzyme products that are FDA approved. And this, while initially seemed like a burdensome thing because it required a significant change in practice, not just on the clinician side, but on the patient and family side, you were used to using certain enzymes your entire life, and then all of a sudden you had to transition to new ones that the FDA had labeled safe and sound. I think of it as a good thing because now at least we have oversight of the production of these products like we do for all other drugs that we ingest and that we prescribe, so that we can feel more confident that pill A has X amount of drug in it or pancreatic enzyme product in it, and that's going to be reliable every batch. It's not going to vary by batch. It's not going to be overstuffed or decay at a variable rate. Additionally, over the years, we've learned that pancreatic enzymes are very sensitive to acid, and therefore products have been developed with enteric coating, which protect them from the stomach acids, so that you no longer are required to take acid-blocking medicines in order to maintain the function of the pancreatic enzymes. So again, going back to why pancreatic function is so important, it is critical for nutrition, for gaining and maintaining weight. It's important to protect against intestinal obstruction. Patients who have difficulty with compliance of the pancreatic enzyme products are at higher risk for developing distal intestinal obstruction syndrome. So adequate dosing to help decrease the risk of intestinal obstruction, and as well as to help with nutrition. Again, abdominal pain and bloating can be side effects from the intestinal obstruction and malabsorption, as well as maldigestion. And finally, vitamin deficiencies, and I'll talk on vitamin deficiencies more specifically towards the end of my talk. There are some key things to think about when you're troubleshooting pancreatic insufficiency. For instance, it seems that you've been taking the same pancreatic enzymes for a while and suddenly that they don't seem to work as well. So one of the things to start with, just going from the top down, stomach. Is the stomach producing too much acid? Is it overloading your ability to get the pancreatic enzymes into the small intestine in a timely manner to start acting on the food that you just ate? So one option that we still use, I think pretty often, is starting acid-suppressing medications, or if one is already on them, increasing the dose, or possibly increasing the frequency of taking it from once a day to twice a day. Perhaps meals are higher in fat content, and the dose needs to be adjusted based on how much fat is being ingested. Timing. Am I taking the enzymes with the first bite of food? And if I'm having a really long meal because I'm with lots of friends and enjoying myself, am I taking a second dose of enzymes midway through the meal if it's been 20 or 30 minutes from the first dose? So I spoke a lot about the pancreas and its impact on the rest of the gut, but what about the rest of the gut? Let's focus on that. Again, abdominal pain has many causes, but one thing that we want to hear from you when you come to your clinician with belly pain complaints is, how severe is the belly pain? Keep track of it, rate it, because sometimes you have a pain that's sort of chronic and always there at a level of 2 to 3 out of 10, where 10 is the worst pain in your life and 0 is no pain. So we want to know, is this really severe pain? Do I start to have to worry about distal intestinal obstruction that's more of a medical emergency, or is this something chronic that has a completely different approach to it? How long has it lasted? Is it every day? Is it a few times a week? Does it last throughout the day, or does it come in just waves of intensity and then subside? What are the associated symptoms? Are you having nausea and vomiting with it? Are you having a headache? Keep track of everything. And what alleviating factors are there? Is this something that goes away when you take some Tums? Or is it something that, you go to the bathroom and you feel a lot better? And what are exacerbating factors? Please tell your CF provider of all the GI symptoms that you have, not just about your cough and, runny nose or whatever. The abdominal component is a significant part of the the disease in general and needs to be addressed in order to maintain optimal health. When do you need to worry about abdominal pain? Any abdominal pain that is interfering with your activities should be addressed. Again, if you have associated loss of appetite, nausea, or vomiting, and if the pain is very severe that comes on suddenly and is associated with vomiting or bloating, that definitely needs urgent medical attention. Pain that occurs daily, you can bring up to your next clinic visit, or ask for a GI consultation if it's if management for constipation hasn't treated it, or some other simple things haven't improved it. And in GI, we like to go with the flow, so things need to move along in the right direction. With abdominal pain and bloating, these are signs of constipation. And as I think I mentioned this earlier about constipation and CF being very subtle at times. So abdominal pain that's associated with fewer bowel movements per day than usual for the past few weeks or months. Or if you have an increased consistency of the stool. So if the stool has turned from a soft consistency to, a harder, more pebble-like consistency, or just sometimes it's described also as like a pasty, thick, peanut buttery consistency that can also be abnormal. If symptoms are relieved by laxatives, but sometimes laxatives that you take over the counter are not enough, or not, what it says on the medication box is usually insufficient to really get all the stool bulk out of the way and really test whether or not it's constipation that is causing the abdominal pain. Treatments for constipation include always at baseline drinking plenty of fluids to keep your gut well hydrated. The function of the large intestine is to absorb water from the matter that comes into it. The entire GI tract moves an enormous amount of water. Normally, in an adult, you have about 9 liters of fluid that are put into the gut by itself and then reabsorbed. And then the colon is responsible for absorbing about just under a liter of water. So if you're dehydrated, if you're chronically dehydrated, that colon is going to want to absorb as much water as possible to help keep you well hydrated. So help it. Take water, drink lots of water. The 10 cups a day of water it's not just a old wives' tale. It really is important. Medications that help with maintaining water in the stool, they're referred to as stool softeners, and the most common and popular one that we have now is polyethylene glycol, also known as Miralax or Glycolax. This is a compound that just keeps water in the stool via osmosis. It just wants to keep a balance. So it's actually dissolved in at least 8 ounces of water, and then you want to take it all together, not sip it over the course of the day. I recommend to my patients to make sure that it's ingested within half an hour, so that all of that water that's dissolved with the Miralax or polyethylene glycol stays in the intestine and helps soften the stool. It is an excellent treatment for constipation of all ages, and we start using it as early as about 6 months of age when infants start drinking water. So it's safe even down to that young. And it is also a very reasonable preventive treatment for DOs. An alternative medication that is being studied now in a couple of centers is interesting. So this medication called lubiprostone or Amitiza was developed for irritable bowel syndrome patients with constipation, and that's the indication that it has approved by the FDA. The way that it works is it increases the water content of the stool by increasing chloride secretion via a non-CFTR mechanism. So CFTR is the protein that's non-functioning and cystic fibrosis, and it's responsible for putting chloride into the lumen, into the intestine and into the lungs, and water follows chloride. It's not the only chloride channel in the gut or in the body. There are many others, and so lubiprostone touts itself as being able to use these other chloride channels. After the drug was released, some additional, investigators that were not being funded by the drug maker looked carefully at this, whether or not that's true, that it's a non-CFTR mediated form of chloride transport. And it is for the most part, but CFTR also is pretty important in the effect of this medication. So although it could work in cystic fibrosis, and it might, it probably will not be as effective as in a non-CF patient. But that really needs to be played out. The study two studies that have been published so far, one was a case series and the other one was a completely uncontrolled study looking at use of lubiprostone in CF adults. And it didn't really change the number and consistency of the stools that they were having per week, but it seemed to overall help with abdominal discomfort. Again, this was an uncontrolled study. There was no placebo arm. It was not randomized. So it's somewhat frustrating when studies get published like this, because this might indicate a negative study, but we don't really know, and more studies need to be done with it. Additionally, there are studies that have used it in mice, and Dr. Dalil used it in his mouse model of CF and found that the mucus production changed in the presence of this medication. Sometimes more mucus was produced, sometimes less mucus was produced, so it's not quite clear. It depended on the model that was being used. So certainly something that needs further elucidation, and hopefully something that could be used in the future. The medication itself does have some other effects on the gut. It delays emptying of the stomach, and this is associated with quite significant nausea in those people that get nausea from the medicine and can limit its usability. And usually you know that within the first few doses of taking the medication. So that might impair its utility. Additionally, again, based on some mouse models, it might improve the fluid and bicarbonate secretion in the small intestine. And if it does help with bicarbonate secretion, then that can certainly help neutralize stomach acid and improve pancreatic enzyme function. And the reason it would help with bicarbonate secretion is that chloride in general, it doesn't matter how chloride got into the lumen, but chloride then gets recycled by a chloride bicarbonate exchanger at the cell surface. So if you do have a lot of chloride that's getting put into the gut, then you are going to get more bicarbonate. And some really nice studies now are showing that bicarbonate is really the key molecule to help hydrate the mucus and to help make that mucus more motile, to allow more particles to move through it. So that, again, something that just needs to be studied more. Distal intestinal obstruction syndrome, or DIOS, again, is a blockage at the end of the small intestine, and remnants of undigested food gradually build up and get plugged in this distal intestine along with the thick mucus. You start off with feeling like possibly some discomfort and bloating or a lump in the right lower abdomen, and this can evolve into a large bloated belly with vomiting. The treatment for DIOS, if there is not vomiting, is actually high doses of polyethylene glycol solution, also referred to as Go Lightly, and if you're old enough, you probably used it for your colonoscopy cleanouts. Not the most palatable solution, but it does help to clear the obstruction. It's administered slowly, gradually increasing the rate as tolerated, but it helps kind of burrow a hole basically through that obstructed part of the small intestine to clear it all out. However, if there is vomiting, then clearly anything from above isn't going to be tolerated, and that's in more severe cases. So an enema with radiology is used to get a fluid that's inserted in that has what we call a high osmolality. So it has a lot of electrolytes in it, or little molecules that draw water, again, into that bulky stool that's in the small intestine, in the lower part of the small intestine, and it helps dissolve it that way and clear it out. There are certain risks associated with that procedure because it has so many molecules in it that draw water into the intestine. It can actually cause a lot of shifts in fluid of your body and make you dehydrated. So usually it's recommended that an IV be placed for hydration and the patient be admitted prior to undergoing the enema. In very rare instances, DO still does require surgery to clear out the blockage. But again, if there's a high level of suspicion from the get-go on the family side, on the patient side, then we can try to treat the DOs before it actually becomes that level of obstruction that requires surgery. Again, going back to prevention, hydration, drinking large volumes of fluid every day is important, and drinking more volume of fluid on hot days. Polyethylene glycol every day is safe and should be used every day, at least once a day, maybe even twice a day. Sometimes we use it 4 times a day. It varies depending on the patient's severity of disease, and as long as it's taken with copious amounts of water, it's safe and it prevents recurrence of the DOs. And again, vigilance, very important. Another problem that we come across, and this one is a little bit controversial because we don't really have good ways of measuring it in cystic fibrosis, and this is small intestinal bacterial overgrowth. You have probably heard from the popular press and many outlets now that there are so many bugs that inhabit our GI tract. Talk about being a germaphobe, don't go to the GI tract because there are probably more, there actually are more intestinal bacteria than there are cells in your body that actually have your own genetic makeup. So you're a repository for so much DNA that is not yours, but that is the bacteria's. So this is altered in cystic fibrosis, though, because of, number one, because of the changes in the pH and just the environment in the gut, but also because of the frequent antibiotic usage. The antibiotics, even though, even if they're IV, but, certainly if they're PO or oral, they alter all of the bacteria that are growing in your gut. They kill off certain ones that are possibly helpful. We call them, the helpful bacteria, the good bacteria in your gut, and they also kill off bad ones. So we have been looking at what the composition of bacteria in the intestine of patients with CF is, and it varies primarily in the types of bacteria, how many different types of bacteria live in the CF gut. It's a much narrower range than in a healthy, normal gut. And this lack of diversity can have significant implications for your health, for possibly how well you digest and absorb the nutrients that you eat. We're learning that bacteria in your gut can determine, to some extent, your risk for obesity versus being on the thinner side. So some bacteria actually take the food that you eat and turn it around, digest it for you, and release really short chain fatty acids that just get absorbed into your gut and become part of your metabolic milieu, or what you have available to use for energy. So when you lack diversity, it's quite likely that a lot of this ability is lost, and so you have a harder time, not only with the lack of your own digestive enzymes and all of those other changes that I enumerated earlier, but now also bacteria that are not helping you in the process. Some of the bacteria can overgrow, and then this is what when we call, we call it bacterial overgrowth when there's like a subset of those bacteria that are always there. A subset grows way more than the others and causes symptoms. And the symptoms that we look for are bloating, flatulence, nausea, and poor appetite. And these, of course, contribute to GI discomfort. The difficulty in diagnosing it is that we don't have a test that we know in cystic fibrosis means what it means in a healthy gut. So there is a hydrogen breath test where, someone is given some glucose, a specific number of, or amount of glucose, and then we measure in their breath how much hydrogen is produced. Your body does not produce hydrogen in its metabolic work, but bacteria do produce hydrogen. So if you have a peak in your hydrogen production soon after taking this X amount of glucose, then that indicates to us that you have a lot of bacteria in your small intestine. That peak usually, we expect it within 2 hours of taking the test dose. If it doesn't happen until 4 hours later, we say, oh, that's probably in the colon, and that's okay, that's normal. But again, we don't know how valid that test is in cystic fibrosis, because the few studies that have been published show that, well, over 50% of patients with CF have this peak early on, but not all those patients have all these symptoms that we associate with small bowel, with SIBO, or small intestinal bacterial overgrowth. They don't have bloating, they don't have discomfort. So it's something that basically I just treat it if I have a suspicion based on symptoms that it might be the bacterial overgrowth, and we do a course of antibiotics, certain types of antibiotics that are targeted a little bit more to the GI flora. And if that helps, then we know, okay, that was probably the bacterial overgrowth. I don't rely on the hydrogen breath test. And one other reason to treat it is not just the discomfort, but actually not in CF, but in, I don't know how many years ago, studies were done on small intestinal bacterial overgrowth and what it does to the gut lining. And it actually does cause damage to the absorptive surface of the small intestine, so that your villi, like these little finger-like projections in your gut, are shortened and don't work as well. So that's certainly something to keep in mind and not shy away from treating if all of the symptoms seem to point to that direction. Again, the treatment includes antibiotics that are given by mouth, and they target GI bacteria. Again, only recommended in symptomatic cases that seem to be affecting nutrition. So if your appetite is blunted because of it, or you just can't eat, you feel full early, then it's worth a shot. And talking about prevention with probiotics has not been rigorously tested. And I think, talking about, Dr. Yang said about the Cochrane database, Cochrane says not enough data available for the use of probiotics in cystic fibrosis. So it's a mixed bag right now. I don't know what to say about using probiotics in general. In a non-CF gut, I say, yeah, it can't hurt you. In a CF gut, I don't know if it can't hurt you. A lot of things are different, and I don't recommend it right now. Okay, so I'm going up and down, sorry. Now I'm back up onto reflux and the stomach and the esophagus. Gastroesophageal reflux affects up to 20% of patients with CF, and the symptoms can include heartburn, abdominal pain in the upper part of the abdomen, an acid taste in the mouth. The reflux can be severe enough that it can affect lung function and vice versa. And, I've always had sort of a debate with my pulmonary colleagues about what comes first. Is it the coughing and all that generation of negative pressure in the chest to bring in air? You're also bringing in acid. Over time, the lower esophageal sphincter, the muscle that separates your esophagus from your stomach, can weaken from all of this coughing and negative pressure generation. So I suspect that probably it's the lung disease that precedes the reflux, but I can't be positive about that. And certainly there are a lot of children that have really bad reflux that their lung disease is better to control when they're on acid-suppressing medications. The treatment for reflux, again, starts with control of acid production in the stomach. And I can talk about these medications in a second. In some cases, though, anti-reflux surgery is recommended. The acid-suppressing drugs include the proton pump inhibitors. Proton pumps are acid pumps in the cells of the stomach. And when these medications are present, they actually irreversibly block the pump in the cell, so that the cell has to produce a new acid pump in order to make acid. You would think that with such a method of action, you would get a pH that's totally neutral in the stomach, but they're still not 100% effective, and so you get a pH of 4 to 5 when you're on these medications. Older drugs are the histamine receptor antagonists. These decrease acid production to a lesser extent than the PPI, and that is because they block a messenger that gets to the cell, the stomach cell, to tell it to make more acid. Specifically, it blocks histamine. There are other messengers. There are like 3 or 4 other messengers that tell the cell to make acid, so you can see why it's not that effective. Sometimes, however, the histamine receptor antagonists are used in conjunction with the proton pump inhibitor. Anti-reflux surgery is done when the reflux is very severe and we think that it really is impacting lung function. It tightens the entrance of the esophagus to the stomach and decreases the number of reflux episodes. It may lead to difficulty swallowing if the wrap is too tight, but usually this is overcome with time. And it can become unwrapped with chronic mechanical stress. So that is something to keep in mind, that with coughing, frequent coughing, it is possible for the surgery to become undone and to need to be redone. There is, in terms of unconventional drugs, misoprostol is used by some, and I think the studies of misoprostol in cystic fibrosis were done in Australia in the early 1980s. The idea is that misoprostol helps protect the stomach and small intestine from injury due to acid. And it does this in a prostaglandin-mediated way. You basically, the medicine stimulates more bicarbonate secretion in the small intestine, so therefore you get acid neutralization earlier, and then therefore improved pancreatic enzyme function. In theory, this works really well, but we don't have a very robust evidence base to say everybody should be on misoprostol, and it does have some other negative side effects to be aware of. So acid-suppressing drugs, the idea is to decrease acid production in the stomach, get a higher pH in the small intestine so that you get a quicker time to optimal pH for functioning of the pancreatic enzymes, improve digestion of food, and improved weight gain. Nutritional deficiencies are frequently manifest in cystic fibrosis, even in a well-nourished patient with cystic fibrosis. Fat maldigestion and fat malabsorption primarily underlie the deficiencies. And the fat-soluble vitamins are those that require a really adequate fat digestion and absorption in order to get good numbers of, or good amounts of. Deficiencies in vitamin A lead to eye disease. Vitamin D deficiency leads to bone disease, and as we're learning more, problems with your immune system. Deficiencies in vitamin E can give you nerve disease, and in vitamin K, deficiency gives you blood clotting problems. Essential fatty acids are those that we do not make on our own and we have to take through our diet. These are omega-3s and omega-6 fatty acids. And mild deficiency in these is common in CF, and Dr. Friedman in Boston did a really nice set of studies on the fatty acid profiles in patients with cystic fibrosis, and they basically are very, very difficult to normalize. Supplementation may help and may have no side effects, but again, this is not, we don't have robust data to support this, and the Cochrane review says we need more data. Flaxseed oil, cold water, fish oils have the omega-3s in high numbers, but we don't know how much to recommend and how often to take it. Zinc is a very important mineral, micronutrient, that is important for the integrity of the skin and the lining of the intestine. I haven't seen any studies really on zinc deficiency in cystic fibrosis, but it's one of those things that as gastroenterologists, when the gut isn't working well, we say, hey, is there a zinc deficiency? Maybe it could help. It doesn't hurt. It doesn't hurt. So that's one that we definitely consider supplementing if there's problems with growth or, despite optimal pancreatic enzyme dosage and calorie intake. The goal is to have a BMI in the 50th percentile or greater because this has been associated with better outcomes in cystic fibrosis. And the question is how to get there. We need to start early in infancy. We need to keep a positive attitude and not battle with our children over eating. We need to keep a regular schedule for meals and snacks and try to avoid grazing because grazing blunts the appetite and you end up eating less over the course of the day if you're allowed to graze throughout the day. So limit times for meals and snacks. Formula supplements and high-calorie shakes can be very helpful if they're taken. If they're not palatable, if it's a struggle, then it's not very helpful. Other ways that increase calories in the meals can be more sustainable, and fat, as we know, has the highest calorie density, and that is why we recommend a high-fat diet. When do you consider a gastrostomy tube in children? When do you consider a gastrostomy tube? This is a question that never has an easy answer. When I talk to my pulmonary colleagues about it, I say definitely if a child's weight is below the 10th percentile, we have to act. If there is impaired height growth, that is actually a sign of stunting, of nutritional stunting, and that is actually a late sign of nutritional stunting, so you have to act. If there hasn't been weight gain in a year because of frequent illness, that's another time to act, and if all non-surgical alternatives have failed. In adults, the adult CF patient who is unable to maintain their weight despite a high-calorie diet, including nutritional supplements by mouth, and if the BMI targets are unable to be sustained. The new treatments that you've heard about, I think, yesterday, CFTR correctors, they fix the root of the problem in CF. However, pancreas that has been damaged are damaged for life. And so we always will have to pay attention to the pancreatic function and the GI tract. Ivacaftor is approved for patients with G551D, but we recently heard news from Vertex that they have some additional mutations that it works really well for, and they're doing combinations so that we're really hopeful to have an effective treatment for cystic fibrosis of all types very soon. So in summary, CF affects almost every aspect of the gut. Digestion and absorption of food is impacted. So please bring any GI symptoms to the attention of your CF provider, as optimal symptom control results in improvements in nutrition and overall health. Thank you.
Thank you so much, Dr. Yan. That was really informative. Now is our question and answer period. So I want to invite people to come to the microphone, to line up. We're going to be sterilizing the microphone between questions for the protection of everybody here. Please, one question per person. Thank you.
We keep winning the race to the mic. Quick question about the supplements. So you're guarded a little bit about how you recommended them. If you like them, take them. When? So if you take them as snacks, is that a good idea, or should you be taking them with your meal, or is there a better way to take them?
That's a really good question. I deal mostly with, I'm a pediatrician, so I deal mostly with the nutrition in the young ones. And particularly, I find that the younger the child, the liquid nutrition goes in more easily. And so if you're trying to get your child to eat more solid foods, eat a greater variety of solid foods, if you introduce that nutritional supplement as a snack or at the beginning of the meal, you're not going to get much of the solid food in. Depending on what the target is, you know, how underweight the patient is, and how much overall they're eating, I recommend a supplement maybe right before bedtime. And if breakfast is a light meal, you know, usually breakfast there's not a lot of time for, so one with breakfast along with other solid foods. And if school snacking is difficult and that's an easy little bottle to open and take, then I'm okay with that. But with the young kids, I work with the dietitians to really recommend high-calorie ways to modify the solid food to try to get more in that way, and then the nutritional supplement, keep it for, like, you know, the nighttime bottle type thing, and with breakfast.
Thank you, great talk. I have a question regarding adults with GI issues, so this might not be fair since you mostly work with children. So I'm curious about children who grow up with pretty severe GI DOS issues and then have family history of colon issues. At what age for adults would you recommend pre-cancer screenings for CF adults?
Yeah, that's a really excellent question. Earlier than it is recommended for the general population, because we don't completely understand the changes in the immune system and cystic fibrosis. We know it's not totally normal. We know that CFTR is present in many of the cells that work in the immune system. So therefore, surveillance of the colon of the immune system, surveillance by the immune system of the colon to kind of get rid of precancerous lesions may not be perfect. And we'll probably get more data as more people with CF live to older ages, but my sense, and this is not completely evidence-based because I don't think we have the numbers to say that, but my sense from speaking with other providers is that the cancer risk presents itself much earlier in life. And so that screening, certainly if there's a family history, should probably be done in the 20s. Just an initial screen, yeah.
Hi there, Dr. Yen. Thank you for your wonderful talk.
Thank you.
And I have a question. Well, I have a list of questions, but I'm going to spare you and the others. First of all, my sister is dealing with small bowel malignancy, and at a Mayo Clinic, she was treated with something called gastrografin challenge, and I love that word. But it's oral gastrografin, and try to push things through. And the doctors had no idea if this has ever been used in CF, and I'm wondering, I mean, we've had gastrografin enemas,
Right.
but have you ever treated patients with CF DOS with the gastrografin challenge orally?
I have not. I think we seem to have really good success with the Go Lightly preps, you know, for early DOS, and so it hasn't been necessary. I imagine that the gastrografin challenge would be a smaller volume, so it would be interesting to look at. You know, that's the one that I said that there are a lot of fluid shifts in the body when you take that medicine by mouth or rectally. So it would have to be done in a very careful, controlled setting. But you know, so is Go Lightly when we do it for DOS management. But so that is an interesting application. She's had success with it.
Yeah.
Yeah, that's very interesting.
And my other question is sort of my personal life goal is to reduce the secretions in the intestine. And I don't really know how to do that. I've been trying random things, and I probably would not recommend that for people. But, I mean, do you have any success with patients drinking Mucomist or NAC, Pharmanax? And do you think it really actually does anything?
Yeah, it's associated with so much nausea, and I've only battled with patients whenever I've recommended it. So like it's gone in their mouth, across their mouth once, and a complete refusal to do it again. So in theory, it works, right? The mucomist breaks down the mucus. But does it get all the way down to the ileum where the problem is? I don't know exactly. You know, one thing that I really want to look at is the use of bicarbonate, because that seems to be really the important molecule to help solubilize the mucus, and that is much safer. So if we could get some, you know, delivery of the bicarbonate further down the GI tract, that would be really good.
So just to clarify, if you're on a PPI, and does that itself reduce the bicarbonate?
No.
No.
No. The
Okay.
PPI just decreases how much acid is put out by your stomach. Bicarbonate is produced by the small intestine and by the pancreas. So you want more bicarbonate production. It is, in general, like even pancreas aside, in general, bicarbonate production in the CF gut is down because CFTR doesn't work, yeah.
Last question.
I have a teenager with CF, and we've been the last few years battling obstruction whenever he's in for lung issues. And it seems like depending on who the doctor is, we try all different treatments, gastrografin, mag citrate, mucomist, go lightly. And is there any like gold standard recommended procedure or things you try first, or is it just whatever they've been taught, they throw at it, or it's kind of
For the distal
frustrating.
intestinal obstruction
Yeah.
syndrome for DOs. The recommendation is to first go with the go lightly. Mag citrate, I think, works more in the colon than it does in the small intestine. So the advantage of the go lightly is that it comes ready to work. And, you know, the mucomist had been used a while, you know, in the past before I started practicing, and I've tried using it, but again, it's been difficult to.
What I wanted to say about that too is we found finally that he would drink it with Coke because it overpowers the taste. Nothing else worked.
And no nausea with that?
Nope. That was the
Oh,
only thing that worked.
With Coke?
Yeah.
Okay.
Anyway,
All right.
so it's kind of, I guess it's just whatever works for
Yeah,
a
yeah.
person.
Yeah, it's, you know, that's the problem with rare disease and evidence-based medicine is that it's difficult to establish evidence bases when the numbers are small.
Thank you.
Thanks.
Thank you so much, Dr. Yan.
Thank you.
So Dr. Yan will be on our Ask the Experts panel this afternoon. So if you have other questions or you think of something in the meantime, come back for that and you'll be able to ask her then. Why don't we all take a minute or two to stretch?